This meeting is being recorded.
Good afternoon. Welcome back to part 3 of pain management. My name is Sam and I'm the West Hume Aged and Disability Palliative Resource Nurse. And we have Chris Keogh with us again, the clinical nurse consultant that works at GB Hospital out in Shepperton. And I'm going to hand over to Chris now so she can talk to us about pain management.
Thanks, Sam. Thanks. This is part 3 of the talk on pain. In the first session, we looked at what is pain and the pain prevalence and physiology of pain, and also the different types of pain. In part 2, we looked at pain assessment, which was a much shorter session. But today, our focus is on the management of pain. So one of the most important things to look at when we're looking at management of pain is to just make sure that we've done a thorough pain assessment. So a good pain history is important, and it also includes a thorough pain assessment. The things that we want to be looking at are the site of the pain, so where it is, what type of pain it is, so we get some idea of the way that the patient will describe the pain, any exacerbating or relieving factors, how often people have the pain, how this affects how they're living, so what they're able to do and what they're not able to do because of the pain. Do they have a response to past and current analgesia? Does it work? Often we ask people if they'd also keep a pain diary, because that gives us an idea that when we next come to see them, we do have an idea of how the analgesia is working and how the pain is affecting them. And also to discuss any fears or issues regarding pain or the analgesia. What happens if pain isn't treated properly? We know that people often experience poor appetite, and from that they get weight loss. They get disturbed sleep, so they're unable to sleep, often being waked by the pain. They may get withdrawal from talking or social activities because they find it too difficult to socialise if they've got a lot of pain. And we also know that it affects our mood. So untreated pain can cause depression, anxiety, just a general mood depletion, so sadness. People can become physical or verbally aggressive if they've got pain. Or as people get older, we do notice that elderly people with pain often have wandering or acting out behaviour. They don't want to partake in care, so it's quite difficult to help them. These are all often consequences of untreated pain. And the big one probably is difficulty walking or transferring. So they may become bedbound. And if they are walking around, they often experience falls. So what are some of the goals of pain management? Well, obviously the big one probably is to decrease pain. Obviously we want to try and make sure that people are comfortable. And by decreasing the pain, we often decrease medical intervention. But one of the goals of pain treatment is also to enhance functioning and reduce suffering and distress. So while it's rare to eliminate pain completely, or I shouldn't say it's rare, but we sometimes aren't able to eliminate pain completely, it should be possible to control pain to a tolerable level and allow people to be able to function. So we should be able to improve their functional status, increase their ability to perform daily activities, and hoping by that we can then improve sleep and decrease anxiety. So we often have different interventions to manage pain. The first one is non-pharmacological interventions. So things that don't involve medication may include heat and cold applications, massage, relaxation therapy, exercise. Exercise is also a very good way to try and eliminate pain, especially musculoskeletal pains does improve by exercise. Physical therapy, so OT and physio. Physio probably goes a bit along with the exercise. And then if people are having, a lot of counselling or a bit of psychosomatic type pain, sometimes counselling can help. And interestingly, people that smoke often experience greater pain than people who don't. And that can be because of peripheral shutdown. So, you know, when there's not as much blood supplied to our hands and feet, they can get quite painful. So ceasing smoking can actually sometimes help. And weight reduction often is related to being able to move around and exercise. So non-pharmacological pain therapy, the goals are really to decrease fear, distress and anxiety and to reduce pain, and also helps to provide people with a sense of control over what they're doing. So when we're looking at non-pharmacological interventions, we're also looking at people's age, people's developmental level, their medical history and prior experiences, and their current degree of pain. So what sort of pain level are we looking at? If people are they've got anticipated pain prior to doing physical activities or exercise, then they can use some of these non-pharmacological interventions prior to having to do that. And one of the big advantages of the non-pharmacological interventions is that they're often easy to access and inexpensive as well. So some of the use of non-pharmacological and adjuvants with opioids, I just put this slide up because it looks at all the different types of strategies, medications, non-medication things that can be used to actually help to manage pain. So in this chart, they've actually divided it into somatic and visceral, or nociceptive pain, or neuropathic. So, and it gives us a very clear idea of what applications, I guess, would help what types of pain. So if we look at under the tissue here, other than muscle, like heat and cold, irrigation, so cleaning something out, keeping it immobile, paracetamol, simple old paracetamol, steroids, so non-steroidal anti-inflammatories, often on muscle damage, and then they can use opioids, radiotherapy, topical non-steroidal anti-inflammatories, or topical anesthetics such as lignocaine, or topical opioids. Sometimes they use topical opioids. We used to use them with pressure areas and things. And then skeletal muscle, so baclofen, so stopping cramping type pain, clonazepam, which is a benzodiazepam that helps you to relax as well, diazepam being the same, but also the same things, heat and cold, immobilization, massage, non-steroidals and opioids. So a lot of them do crossover. With smooth muscle, so that colicky pain might be heat or cold or antispasmodics, sometimes things such as buscopan, and then, you know, just generally opioids as well. With deeper visceral type pains around the organs, which might be a constant pain, we usually start with something like paracetamol, but might need to use steroids or opioids, and in rare cases, ketamine, which is a rather strong medication that we don't use a lot of. Now, neuropathic pain, we often use opioids or tricyclic antidepressants, such as something like amitriptyline. Often now the mainstay of neuropathic pain management is gabapentin or pregabalin, so those anti-epileptics, anti-arrhythmics. I've never used those myself, but they say that they can be used for neuropathic pains. Steroids, ketamine, capsicum spray, I think that is, nerve block, and intrathecal opioids. So quite a large range of different types of medications that can be used, or different types of pain management strategies. So if we look at our analgesics and opioids, I've just broken them down into the analgesics and weak opioids, so paracetamol, non-steroidal anti-inflammatory drugs such as ibuprofen, so the Nurofen, codeine, and tramadol. They're they're analgesics or weaker opioids. And then the strong opioids that we mainly use in palliative care are oxycodone, morphine, hydromorphone, and fentanyl. So we often say our mainstay of treatment in palliative care is analgesic. And really the choice of analgesia is really dependent on the severity, the type and the severity of the pain. So mild pain here is usually managed with one of the weaker opioids, so paracetamol or non-steroidals. And in palliative care, the use of a weak opioid such as codeine, we generally limit the use of that. We don't use a lot of codeine in palliative care. One of the reasons being is that it can cause severe constipation as a side effect. Non-steroidal anti-inflammatories can also be used for moderate pain. So something like inflammation or tissue damage. So sometimes we use that as an adjunct. So as an addition to an opioid, we'll use non-steroidal anti-inflammatory drugs in bone pain. So often with cancer that might have gone to the bones. Opioids usually are required for that moderate to severe pain. The most common opioid used in palliative care, these are the most common, so as I mentioned before. And the mainstay really of analgesia and opioids should still be morphine. When we use a strong opioid, we should use it as a sustained release formulation, and then we often prescribe a PRN dose as well, or we should. If we're looking at adjuvant analgesia medication, so something that we use with the stronger opioids, it just refers to medications that are co-administered, so used with analgesia to either enhance pain relief or manage some of the adverse effects. Non-steroidal anti-inflammatory drugs are medications which are anti-inflammatory. They've got an analgesic property and an antipyretic, so used to reduce fever. They are among the most widely used drugs in the world. And as I said before, one of the most common ones we use is ibuprofen, but there are lots of others, Voltaren and lots of others that you would have come across. We also use steroids, so corticosteroids. The most common one that we would use in palliative care is dexamethasone. They lower pain by inhibiting some mechanisms of inflammation and reducing blood flow to the area that's causing the pain to reduce edema, so that fluid around it, which often causes more pain. For example, in someone that might have cancer in their liver, it pushes on the capsule around the liver, causing a lot of pain. Steroids often are used in that instance. Or if someone's got extra cancer in their brain, so brain metastases, they'd use steroids to reduce the fluid and the edema around there. One of the most common adjuvant medications we use in palliative care is the anticonvulsant agents, such as pregabalin and gabapentin. We use that mainly for neuropathic pain and works very, very well. Antidepressants, we also use those, duloxetine and amitriptyline, that work effectively also with neuropathic pain. Anxiolytics and antipsychotics, they are also used as an adjunct in palliative care and work quite well to lower some of the pain. Muscle relaxants, so some of the benzodiazepines such as diazepam can be quite useful in relaxing muscles, and once we know that muscles are relaxed, they're less likely to be pulling on areas that will cause pain. Antibiotics we'd use if someone's got an infection. People sometimes with infections have quite a lot of pain associated with that, and antibiotics can work quite well there. Topical non-steroidal anti-inflammatory drugs such as Voltaren gels or Nurofen gels can work quite well to a particular site, and some people, as they get older, really like the topical non-steroidal anti-inflammatories. And then you can just have like menthol and camphor and salicylate, some of the more basic type pain relief that we used probably in the past, that works quite well. Or the other ones we can use is lignocaine patches. And sometimes when people have, ulcerated mucous membranes in their mouth, or they've had radiotherapy, xylocaine viscous can be taken as a topical. So there's also multiple routes of administration of medications. Obviously, the most common is oral. So most tablets that we take them orally. Transdermal, so fentanyl or Norspan, placed on the skin. Subcutaneous. So the subcutaneous route is used by injection just under the skin, so in the subcutaneous layer. The most common injections that we give there probably are diabetic medication, so insulin and Clexane. But in palliative care, we usually just put a subcut catheter just under the skin and don't inject it every time. I'm sorry. The most common sites, as you can see from these diagrams, the preferred site for pal care subcutaneous meds are on the chest wall, and can often use quite well because of ease of access. If people are a bit confused and want to pull out their subcutaneous lines, then often on the back, you can see at the shoulder, just on top of the shoulder blades, or the top of the arms. Can also use the abdomen and the top of the thighs. You have to be very careful when you're using subcutaneous sites that they haven't got any wounds or breakdown or inflammation or edema, because it doesn't work so well. Buccal medicine is a medicine given between the gums there in the inner lining of the cheek, and it's called the buccal pouch, so that's why we call them buccal meds, and something like a fentanyl lozenge would sit in there, which is a little bit different from the sublingual route. So it's placing a medication under the tongue, as you can see in this diagram, and it just sort of dissolves and absorbs into the blood stream through the tissues. An example of a sublingual tablet would be lorazepam. And then we've got epidural and intrathecal. So intrathecal is delivered directly into the cerebrospinal fluid and into the superficial spinal cord, whereas the epidural diffuses through the dura into the CSF. So it has a slower onset, but it is actually a more direct route, and can work quite effectively with nerve type pains that affect our spinal column. And then topical, we just place them on the skin, usually in a cream or a gel. Okay. If 3 or more PRN doses are used in a day, we usually increase the, I'm sorry, Sam, can I stop? I think I've mixed up.
This meeting is being recorded.
We're now going to look at the treatment of pain. So the rule of thumb and common sense rules are use the lowest effective dose by the simplest route. So we start with the simplest single agent and maximize its potential before adding other drugs. So for example, we might just start with some paracetamol and use it 3 or 4 times a day. If we find that that's not working well, then we might add in an opioid such as morphine mixture, and we usually start by using PRN doses to get some idea of how much medication people are requiring. Now, this is in palliative care. This may not be in normal pain relief settings or normal settings, but in palliative care, we often start with something simple like paracetamol or Nurofen or a bit of both, And then we might add in an opioid such as morphine mixture or oxycodone. Then once we've established that there is a regular need for the medication, and we've got an idea of how much pain relief people are requiring, we would put them on a longer acting pain medication, so to manage their constant or frequent pain. So we'd start off, if someone was on Ordine mixture, so that's morphine mixture, we might start them on MS Contin. So MS Contin 5 milligrams twice a day, but still use the PRN morphine mixture to supplement during the day if they get some breakthrough pain. So we need that short-acting medication available for breakthrough. And to treat breakthrough pain, we usually say we use 1/6 to 1/10 of the 24-hour dose. So if someone was on 12 milligrams of morphine in a day, then their breakthrough dose would be 2 milligrams. So to work that out, when we go to someone's place or go to see a patient, if 3 or more PRN doses are used in a day, we usually increase the scheduled dose. So if, say, someone was on MS Contin, so morphine, sustained release medication, 5 milligrams twice a day, and they required, say, 4 breakthrough doses of morphine 2.5, which would add up to 10 milligrams, we would probably increase the scheduled dose to maybe 10 milligrams twice a day. So then we need to check if we need to increase the PRN dose when you increase that sort of scheduled dose, daily dose, or be twice daily dose. So if they're on 20 milligrams of morphine during the day, if we put 6 into 20, it means that the 6 threes are 18. So we probably still keep their PRN dose at 2.5 to 5 milligrams. And we also need to be vigilant at assessing the side effects of the medications. So we need to treat or prevent the side effects such as constipation and nausea. Now we know that opioids will cause constipation. So when we start someone on an opioid, we should always start them on an aperient. So it's important to remember that. And some people get extremely nauseous with opioids, not everyone. So just to be aware of that, if we need to, we will start them on an anti-nausea. And if the side effects are too significant, we should change the medication. So it's just another sort of reminder to don't forget the side effects. So constipation, we should always be monitoring and recording. The hand that writes the opioid prescription should write the laxative prescription. So Caloxyl with Senna, which is a stimulant and a softener, or you can try or Movicol, which is an osmotic laxative. So it pulls water in to the bowel. So nausea and vomiting, as I mentioned, may require an antiemetic. And another side effect of opioids is urinary retention. So we just need to monitor that, keep an eye on that. So pain management in the elderly does have some extra risks that we may not necessarily see in the general population. So the frail elderly are at risk for both under and over treatment of pain. Non-steroidals and paracetamol basically are effective and appropriate for a variety of pain complaints. So non-steroidal anti-inflammatory drugs, there's always a gastric risk, so they're not that kind on people's stomachs. So we do need to be aware of that. Sometimes people need to be on a protein pump inhibitor, so a PPI as well. And non-steroidal anti-inflammatory medications can also affect our kidneys. So we do need to have some idea of what the renal function is before we start patients on those. And sometimes unusual drug reactions are more common in the elderly. So as staff, when we're looking after patients or residents, we must be aware of side effects and there must be an effective communication method for staff to know some of the adverse drug reactions so that they are keeping a bit of an eye out for them so we know what's actually happening. So one of the reasons that we get changes with our medications is that there are age-related changes as people get older that affect analgesics. So our total body water decreases. So this increases the serum concentration of our water-soluble drugs. So basically there's more of them floating around in our body. So higher drug concentrations can cause more adverse reactions. So changing body weight influence appropriate drug dosage and how long it stays in the body. So if we've got more body fat that sometimes people can have as they get older, they get a prolonged half-life. So the medication stays in our bodies longer. And if there's a less lean body mass, then there's going to be an increased drug concentration in the body, causing a greater effect of the medication, I guess. And sometimes we can look after the elderly that are quite emaciated or cachectic. So we do have to be a bit careful, a bit like children. When we're looking at medications for them, we might need to give a lower dose for these people. And our digestive system changes as we age. So the speed of drugs getting into the bloodstream, because we've got, as people age, they have reduced gastrointestinal motility, so things don't move through as quickly. They also have altered pH, or can, and they can also have reduced absorption as well. So there's changes in the body system that actually can affect the way that the medications are either absorbed or broken down in the body, which is important to remember when we're looking at elderly, because their analgesic needs are different to just the general mainstream population. So patient education is essential. Patients should understand, what is hurting, why it hurts, what can help, why it can help, what the time course is for treatment and alleviation, and what, if any, are there any other options? And we as staff should also know, we need to do good pain assessment so we know what is hurting and why is it hurting. It's always a good idea to ask, if someone says they've got pain, to have a think about why would someone have pain in that area, or what would be causing that, because that will help you decide on what medications might be the most appropriate. And we can empower patients, residents through information and create a very good care plan that's collaborative, so it's individualised and meets their needs. So in summary, we need to educate patients, families, residents and other clinicians to use analgesic medications prophylactically, so prior to and after painful procedures. So for some people, if they have a lot of pain when you're showering them or moving them or getting them out of bed, then they might need to have some pain meds prior to these procedures happening. Teach about pain medications and their adverse effects and issues of tolerance. So over time, people can become a little bit more tolerant. So we may have to sort of mix them up a bit or change the amount. Educate about it's important to take medications at the right time on a regular basis. That can always help with pain. And try and encourage people to avoid allowing pain to escalate. So try to get them to take something for pain when the pain's 4 out of 10 rather than 10 out of 10, because we know ourselves it's much harder to control once it's out of control. And then we should also use, along with our analgesics and opioids, use non-pharmacological strategies to manage pain, such as relaxation, massage, use of heat and cold, even just to try and reduce anxiety for some people can help. And there's just some of the references that was used to put together this talk. So thank you for listening.
Thank you very much, Chris, for joining us on this education session. I'm going to stop the recording now.